Okay, Tayson.
We were saying that there's
Now that you
asymmetric
know the answer.
atrophy. Yeah. Asymmetric atrophy on the right, probably long-standing.
Yeah.
And answer is
And marked atrophy of the muscles. We've
yeah.
seen this before. This is very characteristic of polio. This is a characteristic deformity you can see in polio when it involves a child's muscles here, so they no longer get proper traction upon the femur.
Okay.
And here we can see the focal atrophy due to the denervation from polio. Okay.
Okay, so here we see bilateral muscle atrophy, worse on the left. Um, yeah, deformity of the right hip joint. Um, hmm. I mean, could this be, again, polio or... Okay.
Yeah, again, polio with marked muscle atrophy, really. With that, you get instability of the joints because you can't control the muscles anymore, and you can get instability patterns like this. Okay, Robert, John.
Polio is very spotty in terms of what it affects in terms of muscles.
Yeah.
So it's not a symmetrical disease.
Right.
So you'll see it in the hip, then you'll see it in the foot, you'll see it in the back, you see it every different place. But you don't get a bilateral same place disease. It's just spotty.
Right. Depending on where it attacks the nervous system. Thanks, John.
All right, so here looking at the right hip, it looks like there's a lot of destructive change of that femoral head and a large joint of fusion, a lot of erosive change of that.
What comes to your mind as soon as you see that? What's the first thing that comes to your mind?
First thing I would think about is infection.
Yeah, me too.
Yeah, the second thing, trauma. So this is a monoarthritis. So obviously the first thing you have to like it's chronic. But hopefully if it's an infection, you pick it up right away, you treat immediately. That's really an emergency, one of the emergencies in musculoskeletal imaging to make sure that you give the proper diagnosis and treat with your proper antibiotics. So always think of infection first. And then I don't know the history in this particular patient, but also then you'd have to think about prior trauma, but this was probably a prior infection.
Something old about that because there's muscle atrophy and it's a, uh,
And um, maybe some asymmetrically increased signal on the right acetabulum.
Okay. So what do you think is going on here?
I'd consider
Right hip pain. So you have edema within the
Yeah.
acetabulum.
and then some small effusion. So I'd think about a septic joint.
What?
I'd think about a septic joint.
Okay, that's the first thing I would think about too. Could also be
when you say a small effusion, what do you mean by that?
trauma. And here we can see the fluid. We can see fluid going up into the bursa here. Oh, along the iliopsoas, and this was staph arthritis, and associated osteomyelitis. So this grew staph aureus up and had to be treated right away.
All right, increasing pain after trauma. Uh,
Hip infections are common in
yeah, I see
older people
some
and children. So
periosteal reaction, proximal femoral diaphysis.
You want an MR?
Yes. All right, so a lot of edema within the medullary canal and also through the periosteum as well. Is this a subperiosteal hemorrhage? Or
With edema in the surrounding soft tissues. Okay, increasing pain after trauma.
get closer to the mic.
Closed or open trauma.
yeah.
Right? So what's your differential?
Some sort of infection.
Yeah, it's very diffuse here. Trauma is usually more localized when you have a bone, depending on the nature of the trauma. You see a lot of edema in the surrounding subcutaneous tissues, and then this kind of chronic thickening and increased intensity really looks more like a chronic type of osteomyelitis
Okay.
with involvement of the cortical bone here, and a lot of cortical bone involvement. It doesn't look like the more discrete injuries that you'd see in an acute infection. And what are we seeing here?
Looks like we have some break of the cortex there and fluid surrounding it. So
Yeah,
this,
so we worry about pus coming in
yeah.
here. And maybe a little bone there,
Makes it easier for a surgeon to drain it.
increased symptoms because of the increased activity of the infection.
Okay.
Very difficult to treat. John, do you want to talk to us about chronic osteomyelitis?
Well, I've
John?
seen my share of it, but in this
John again?
situation, what you
John,
have
you
to
with
do
us?
is, pardon me? This is a surgical case. You're not going to cure this with just IV antibiotics.
Again, he did it again. John, are you with us?
I'm with you as far as I know.
Yeah, I just couldn't hear you because this program did it again to us. So do you want to tell us anything about chronic osteomyelitis? Don't tell me we lost John again. John, are you with us?
Yes.
Do you want to tell us anything about chronic osteomyelitis?
Well, chronic osteomyelitis is, I'm not sure that it's permanently treatable. No matter how hard you work on it, there's a tendency for it to come back. Um, you clean out everything, you use antibiotics, sed rate goes down, and etc. And then you get another lesion later.
Yeah.
It's very, very difficult to treat. That's why the best thing is to treat them initially and treat them with every gun that you have in your possession.
Yeah, great. Thank you.
And you have to drain them with otherwise they just won't heal.
Okay, so here a 46-year-old female excisional biopsy for grade 2 liposarcoma in August. Positive margins led to a CT in October and further resection in October. Okay, so pre and post contrast CT, we see I think where we hear the medial side of the thigh, we have this
Lateral.
a lateral, okay. Within the musculature, you see
Vastus lateralis.
vastus, yeah, in the vastus lateralis, this
Okay.
ringed
So this
enhanced.
is on 10/1/09.
Mhm.
Okay, and then the patient came back on 11/27/09 with an enlarging mass after the second surgery.
Okay, so on the PD fat set on the left or on the right,
Uh-huh.
yeah, we see this. It looks like fluid.
Yeah, with some edema in the surrounding soft tissues. Here's T1 fat sat pre and T1 fat sat post.
So ring enhancing fluid collection. I think it's an abscess.
Yeah, so this was a staph abscess. Yeah, good.
Even a biopsy will get infected, so it doesn't matter the size of the incision. It's the kind of patient you're dealing with.
Thank you.
All right, so we have a 38-year-old female with AML and vague thigh pain. And looking at the left thigh, it looks like there's a lot of edema in that posterior medial musculature there. Yeah.
Okay.
4 weeks later, those top images with contrast, or
This is with contrast on the right. This is with contrast down here.
okay,
These are without.
gotcha.
PD fat sat and T1.
So it looks like there's a fluid structure there that's peripherally enhancing, and some edema in the adjacent musculature that also enhances. Just another abscess.
Yeah, another staph abscess.
Now, what would you do with that? Other than call an infectious disease specialist.
Oops.
These have to, I'll go to get to the chase. You drain these, you almost always have to drain them.
Yep.
These wall off, especially staph. It walls itself off, and antibiotics don't get to it, so you have to excise it
Thanks, John.
or incise it. Incise it or excise it.
Okay.
So looking at a axial CT at the level of the pelvis, looks like peripherally, I don't know if it's enhancing, but hypoattenuating or enlargement of this left psoas muscle with hypoattenuating area.
Yeah. And here, and
Concerning
also there. So there's marked symmetry in this old CT scan from the early days of CT, the early days of MR. We can see the fluid collections here on both sides of the iliac bone. And oops. Yeah, and here we have it. And this is just a large abscess with osteomyelitis of the iliac bone. Jason?
All right. Asymptomatic mass, right? Abdomen palpable. Guess there's this large fluid collection. Looks like it's coming off of the right psoas muscle with rib enhancement.
Okay. See it in other planes.
Yeah.
Shows.
So it's, I'm sorry.
Psoas abscess.
Yeah,
That's what I was going to say.
yeah. This is a abscess formation from an unusual organism.
Yeah.
At least for the United States. This was a Korean case.
Okay, so I see soft tissue thickening and scarring in the kind of posterior thigh.
Does that look like a sinus tract to you?
Not sure. Not
So
really.
this was an elderly cachectic lady who was bedridden.
Mm-hmm. And there's that dark
Bed
signal.
sore with an infection.
Mm.
Yeah, so these are bed sores from not turning the patient. And you get,
Very, very common in nursing homes.
you get necrosis of the skin, which then gets infected. And, right. Okay.
And obviously, this patient doesn't walk.
Right.
All right, so we have a 36-year-old male, multiple subcutaneous nodules and purulent discharge at both buttocks for 1 year. Yeah, looking at the subcutaneous gluteal soft tissues, there's a lot of nodular, fluid-like signal back there.
So what do you think is going on here?
I mean, is it chronic bed sores or?
Yeah, it's called hidradenitis suppurativa. And it's another one of these things that's going to be very difficult to treat because of that chronic, you basically get pressure necrosis and infection of the subcutaneous fat. Starting out really involving a lot of the organelles of the skin. That's what it looks like. And again, it's usually in people who really aren't walking. Okay.
42-year-old male with a thigh mass. So at
This is a Southern California case.
Southern California case. Okay, so we see a soft tissue mass at the, essentially, looks like it's arising from the left upper thigh.
Yeah, the medial aspect of the left thigh, the whole thigh. Here. Go to the axial images, it looks like this. T1 images and PD fat site images. And as we go back here on the coronals, we compare it. You can compare it to what the other side looks like.
Yeah, it almost looks like it's muscle. There's striations within it.
Yeah, well, but it's not muscle. So what else could it be? It's a very
Far from it.
characteristic appearance.
Striated kind of appearance like that.
Most of these cases you would see in Africa. Actually.
It's named after an animal in Africa
Oh man.
and India.
Okay, so this is
Elephantiasis.
elephantitis.
Oh, elephantitis.
It can look pretty gross at times.
Oh.
So what's elephantitis due to?
Trichomonas, or isn't trichomonas? Is that what it is?
Well, like I'm blanking.
Filarial.
Filariasis.
It's obstructing the lymph.
It obstructs the lymphatic system, and you get these
So-
large areas of lymphedema.
Lymphatic system is involved.
And that's why it looks like this. This is actually obstructions of the lymphatic system, and they build up with fluid within the lymph. It occurs over long periods of time, causing expansion of the soft tissues. Okay, Jason?
They probably got that one from a circus.
Multiple masses, both thighs, eating snake without cooking.
30 years.
30 years ago. Okay, so we have some patchy stuff in the lungs there.
Yeah.
Abdomen, couple calcified lymph nodes, maybe. So some sort of granulomatous thing going on, or is this?
Well, these are all calcified.
Yeah.
Well, there's a calcification. See some over here too.
We have some right and left thigh calcification too.
So what did you always worry about when you ate raw snake?
Some sort of parasite.
You're right about that.
Just yeah, Yeah, I don't know which parasite.
Okay. Sparganosis.
Sparganosis.
Kind of characteristic. Tapeworm.
I don't know too many people that would eat a snake raw.
I don't know many people that would eat a snake.
Period. Right? It's just the life cycle of the
But
sparganosis.
there are people that love eating snakes, though.
Yeah. Well, we'll see some more sparganosis because it's a favorite disease of Dr. Su in South Korea.
Mass had raw snakes in military service. Yeah, we see these linear
Until you get
calcifications.
hungry enough, Ross making this
Is that Vietnam or Thailand or
sparganosis,
someplace?
typical calcifications.
All right, here we have a 3-year-old girl, pain after a fall. Looks like there's there's thickening of the femur cortex, and then it looks like there's a fracture, kind of, yeah, right there. Yeah, definitely a fracture
Is
there.
it pathologic or fracture?
Striated periosteal reaction,
Mhm.
almost a bone-in-bone configuration for the femur.
Oh, yeah. Yeah, again, cortex looks very thickened, and then there's a fluid collection down there by the fracture site.
It's a pathologic fracture.
All along the periosteum.
Mhm.
Okay. It shows this massive periosteal reaction fluid. So this is chronic osteomyelitis with an abscess and fluid collection.
"38-year-old male, pain after fracture." So looking at the mid diaphysis of the right femur, there's a deformity of the mid diaphysis.
So it looks like there's an old fracture. It looks like it healed with a lot of deformity.
Right. And then adjacent to that, there's a little fluid collection with a tract.
Tracking out of the bone.
So,
What are you concerned about?
again, osteo.
Probably a little bone fragment. Side. Yeah, so another case of another type of appearance of chronic osteomyelitis.
It was probably an open fracture.
All right. Got a lot of increased signal at the pubic rami there, and also within the left femoral neck, maybe. Yeah, it looks very amorphous in that region.
Let's see. Stuff in the bone here too. This is fat.
Where
See when there's a lot of extensive atrophy of all the muscles. So this is probably another bedridden patient. And this is symptoms of pubis osteomyelitis.
Okay, 63-year-old woman with increasing painful swelling over the symphysis pubis, fall, and open rami fractures 2 months ago.
Suture at a local clinic.
I mean, there's lucency in the left pubic bone adjacent to the pubic symphysis.
A little sclerosis here too.
MR shows, marked edema surrounding the pubic symphysis.
And all around the surface, soft tissues as well. Okay, so they IND'd this and it showed chronic osteomyelitis. Okay. Robert.
All right, so here we have a 73-year-old female looking at the pelvis. Again, the pubic symphysis, there's a lot of erosive change and Looks like some soft tissue swelling there as well. Here, yeah, looks like there's some soft tissue, well, some bony edema and some loss of the normal cortical structure of the bone there. Yeah, some erosive change.
Okay.
Nothing. See blue lines? No, I can hear you. What's the treatment for that?
I think in the past he used and banish them there.
So it's a bacterial infection, so it's antibiotics.
Tetracycline or doxycycline?
And then we still, I think, a couple of years ago, we occasionally get outbreaks of plague in Southern California, various places. So it's still
Cipro?
another abscess with osteomyelitis.
Okay, so here, left intertrochanteric region, we see some fluid in the bone, surrounding edema in the soft tissues, fluid connecting to the bone with the cortical break.
Yeah, well, it's okay. Yeah. So what do you think's going on here?
It could be an infection.
There was not a draining sinus. I mean, you have to kind of think about that looking at this. So this was osteomyelitis, and it broke through the cortex and extended out into the soft tissues.
With drainage.
All right, so here we have fixation of left hip fracture. Looks like some heterotopic ossification of the lesser trochanter, but the fracture I think is probably healed.
You ignore those. We don't treat them.
61108.
Here it looks like they've removed the hardware.
Yeah.
Yeah, but
So they removed the hardware
before they removed the hardware, look at it.
It was fine on 61108. Then it came in with increasing pain on 7108.
Oh, jeez. Yeah, looking at that T1 weighted image, there's a lot of fracturing. I guess.
Well,
edema
was it healed?
Acetabulum and femoral head. Was there any recurrent trauma?
They took out
no recurrent trauma.
Post-op
They
infection.
took out the screw and the nail, and it wasn't healed.
So-
That's the problem.
And this is all infection.
Before healing, even if it's infected, because that's the only stability you have. And if it's unstable, it's not going to heal.
Okay.
So you leave that in, and antibiotics, massive doses.
Okay.
You take that nail out, and that patient is not going to walk again
Thanks, John.
on that leg anyway.
All right, 10-year-old male. So some radiographs of the right femur.
Okay.
I don't see an obvious abnormality. Oh, so there's a periostal reaction along the mid diaphysis.
Here's the MR scan in that area.
So periosteal edema thickening with soft tissue edema as well.
So here we see the periosteal reaction, a multiple laminated appearance, typical of infection, but you can also see that kind of an appearance with osteogenic sarcoma. But here we can see a lot of edema in the surrounding soft tissues with what looks like a defect in the cortical bone here, not endosteoscalloping. So be much more concerned about osteomyelitis in this particular case. And here we can see some subperiosteal fusions here in this particular young kid. And here on the fat side, we can see a lot more of the inflammatory disease involving the periosteum. And this was osteomyelitis.
The way you treat these, you make several holes, and you just keep washing the inside of the bone until everything comes out pretty clean, and then keep draining until the antibiotics take over.
Great. Thanks, John.
It's not easy to treat.
Is it pretty rare to get it at the mid-diaphysis? Like
What?
Is it rare to get it at the mid-diaphysis?
Not necessarily, no.
Okay.
Okay, why don't we stop here and we'll pick up here again on Thursday. Thanks, everyone.
I'll see you guys on Thursday, but I will not see you on Friday.
Okay,
My son's coming in from Virginia, so I don't see him that often.
very good. That's great, John.
So
Thanks.
I'll miss you guys on Friday, but Thursday I'll be here.
See you Thursday. Thanks.
Take care, everybody.
Thank you.